Hello, my name is Kathryn Mayo, and I'm going to be presenting this webinar on the essentials of implant assessment. I work in the northwest of England at an implant referral centre. I'm also a clinical supervisor for Manchester University hygiene and therapy students, and I teach them about implant supportive care. And I'm also a clinical educator for the Ikigai oral hygiene community. So if we look firstly at the aim of the presentation, to enhance your knowledge of the key components of an implant assessment in support of implant longevity. And then these are our outcomes, which will be on your certificate. So just to give you an idea of what we're going to discuss and what I feel really makes up the key components to a clinical assessment of an implant. We're going to look at the tissue differences between the periodontium and the peri-implant tissues. We're going to look at the clinical implications that arise from those tissue differences and how we may look at our implants in a slightly different way and navigate through treatment slightly differently. We are also going to look at classification. That really is the cornerstone of making a diagnosis. And diagnosis is really all important in terms of making sure that we are correctly treating our implant patients. We're going to look at the step-by-step approach that we would take to a clinical examination of an implant. And also just a quick summary of the kind of subjects or certainly the aspects of implant care that you might want to look at in a little bit more detail. We are taking a clinical exam out of a huge subject here and taking a little bit more of an in-depth look at the clinical exam, but there is a lot more to implant care than just the clinical exam. So if we set the scene, 3 million adults in 2018-2019 had a tooth extraction. 6% of our adult population have no natural teeth. This actually has reduced quite considerably over the last 10 to 15 years, which is obviously encouraging. But this statistic is the one that sort of stuck out for me, really. I was quite surprised that around 76%, so nearly 80%, have lost at least one tooth. So that's our adult population. And in 2021, there was a 30% increase in the interest in dental implants. And that obviously could be for lots of different reasons. They are generally more accessible. There is also the added, I don't know whether I'd call it a bonus, of dental tourism. But for whatever reason, people are feeling that they want to maintain their dentition for as long as possible. The issues that we have to deal with is that in terms of implants, disease rates are actually quite high. So the prevalence of mucositis is at nearly 50%, and some papers put it over 50%. And the prevalence of patients going on to get peri-implantitis are around 20%. And if you think about that's 1 in 5 of our implants will get peri-implantitis, which is quite a high statistic. Where we come in as hygienists and therapists is that there is quite a lot of evidence that we actually can support our patients in reducing that risk of implantitis. So patients who aren't enrolled in a supportive care program, say, are about twice as likely to get peri-implantitis than those that are. So really, we want to be getting that for our patients way before that implant's going into their mouth. And this is from the S3 guidelines, and this was produced around 2023, and it is probably the best paper in terms of guidance for implants, the most up-to-date paper. And they looked at how they were going to actually guide or what recommendations they would make in terms of implants. And they looked at different ways of maybe approaching this. They looked at thinking about an implant as an implantable medical device. So if you think similarly to maybe a hip replacement or something along those lines. But obviously, we have the added complication that an implant that's going into the dental jaw is actually emerging from the oral mucosa and being exposed to a really diverse range of bacteria. And for that reason, you really can't compare it to the other types of implantable devices that we may use within the body. They also looked at being very simply just looking at it from a periodontitis point of view, and are our periodontal tissues similar enough to our implant tissues for us to treat our implants pretty much the same as we would treat our natural teeth. And really, they came to the conclusion that wasn't the case. And this was part of the statement that they produced. The major anatomical and histological differences between periodontal and peri-implant tissues, and the histopathological dissimilarities between periodontitis and peri-implantitis lesions necessitated a different approach. So we really are looking at two separate ways of managing these patients. So to that end, let's have a look at our periodontal structure. And this is really very quick and very simple, just so that I can talk to you about the peri-implant tissues. So obviously, you know, I know you will all know this. We've got our periodontal ligament, we've got cementum, we've got a connective tissue attachment, the junctional epithelium, and we've also got 13 groups of fibres running perpendicular along the tooth. And this really does make a really good barrier, in a sense. It's millions of years of evolution have made this really good way of protecting the bone support from the bacteria in the oral cavity. So it's really robust and it does the job really well. We've got a favourable emergence profile. Don't worry too much about emergence profile because I will go into a little bit more detail on further slides. But really what an emergence profile is how whatever it is which is in the jaw is emerging from the jaw. And you can see here that there's no really sort of acute angles there. You know, we're sort of coming out of the periodontium in a nice uniform way. And there is a good vascular supply. So all the nutrients that the tooth and the gingiva and the bone needs, all of the defense cells, they're there in abundance, doing their job really, really well. Peri-implant structures. So we have an absence of a periodontal ligament or cementum. We've got a connective tissue interface. So essentially that sulcus sits next to the implant and they sit in harmony with a little bit of sort of tightness to it, but it doesn't really have the same resistance that the periodontal tissues have. And the fibres, instead of inserting, they run parallel to the implant. You generally tend to have a longer sulcular depth, which again I will go into in a further slide. And there is direct integration into the bone. So this structure is ankylosed into the bone. So there is very little movement. Proprioception for patients is quite difficult. So unless they've got teeth next to the implant, sometimes they're not really aware of how hard they're biting, whether the bite is actually right or not sometimes. So yeah, it's quite different. And because we don't have that periodontal ligament and we don't have that vascular supply, it's quite decreased, because as you can see on the diagram, you've only really got that vascularity in the portion of the sulcus where the collar and a little bit of the crown of the implant is. And this is a little bit more in depth in terms of those fibres, because this is a quite important point, that the fibres run in a tooth all the way down and they insert. So from the sulcus and right the way down to the apex, you will have Sharpie's fibres connecting into the tooth surface. With an implant, as you can see on the right-hand side here, this smooth collar that connects the body of the implant, so the body of the implant being the bit of the implant that has the threads on, and the prostheses or the crown. So this collar is sort of the interconnecting part, and the fibres will run around and sit next to the implant. So a little bit, if you will, like you put a rubber band around something, they will sit like that. So it is fairly tight, but it isn't certainly that robust arrangement that you have with a tooth. And this is what we were discussing previously about the sulcus, and you can see here that because again of that collar, the smooth collar that connects everything, that you end up with in some cases, a soft tissue dimension which is more increased than a tooth. And I think we talked about emergence before, the emergence profile. So I'm sure we've all had these patients in our chair and we just think, how am I actually going to get an instrument probe even in there? It feels like you may be probing in a horizontal fashion into the implant, and you just don't really seem to be able to get anywhere. So there is some guidance from S3 that the emergence profile should be no more than 30 degrees. And this convex divergence that we see on our right-hand side here is ideal. Just to remember that this image obviously is a 2D image, but we are taking it up a 3D structure, much like we would take in a radiograph, and you will get that emergence in all surfaces or all aspects of the implant. So although this doesn't look particularly challenging, sometimes it can be more challenging because of the emergence sort of mesial distal as well as buccal. So when we look at periodontal characteristics and peri-implant characteristics, obviously there are similarities, there is no two ways about that. And the biggest one being that they look very similar. You know, it's an inflammatory condition, and you know, to all intents and purposes, what happens around an implant happens around a tooth and vice versa. And there are some other theories, shall we say, about etiological factors, but the overriding evidence and the way that the implant community feels at the moment is that it is bacterial biofilm, which is the primary etiological factor. And both are often painless. And I think we've all had those patients, haven't we, that come in and you're doing your best spiel about how they have bone loss, you're showing them the radiographs, you're explaining in great detail that this can be progressive, etc. And the patient comes back with, well, I don't have any pain. And this is just something we need to get across. And even more so with an implant, really, because a patient's perception is that we've actually sort of drilled a hole and put a screw in their bone. And whilst we've done that, if there were issues with it, surely it would cause us pain or discomfort. And I think that we need to disabuse our patients of this notion. They are not going to feel anything in most circumstances until they are in a situation where it is really quite severe. So it's really good to let them know that our monitoring processes are what is going to help to detect any issues. Again, this is another really, really important point. Gingivitis is not a precursor for periodontitis, but mucositis is a precursor for implantitis. So what that means is that patient presents with mucositis. If that isn't detected or treated in a timely manner, they will go on to have periimplantitis. And that is really, really important. Gingivitis, we've all got those patients, haven't we, who are just sort of plodding along with their chronic inflammation, don't really engage, don't really get bone loss. And, those are the patients that we sort of think, oh, great. But we really need to look at it in a different way when it comes to implants. We probably need to look at it in a different way when it comes to gingivitis, because obviously there are lots of issues when it comes to an inflammatory response. But I digress. So we've got more predictable treatment outcomes with a periodontal lesion than we have with a peri-implant lesion. We really don't know how to treat periimplantitis. We try our best and we use and employ the tactics that we would use with periodontitis. But actually, we're not really sure whether we are doing the right thing. And we don't, with a periodontitis lesion, you engage your patient, you reduce the inflammation, you do sub-PMPR, etc. And majority of patients will actually have a really, really good response to that treatment. Implant-wise, it's not the same. So that first line there where it says mucositis is a precursor, we really want to be getting them at the mucositis stage and reversing that back to health rather than having to treat at the periimplantitis stage. Surgical interventions are often required more with a periimplantitis lesion, and a lot more, I would say. If I give you an example, I think in the last 3 years, I've had 2 patients who've had surgical intervention for perio. And in the last 3 years, I probably can't count the number of patients that have had surgical intervention for their peri-implant lesions. So a lot more patients will go down that surgical route for the implantitis treatment. We've got, as a general rule, we have a slower rate of progression with a periodontitis lesion. I want to say general rule because obviously there are always those outlying patients who will have quite progressive disease. But generally, you will find that there is a slower rate of bone loss. And that rapid destruction could be to do, or is likely to be to do with the tissue difference that we talked about, the histological differences there. So we generally tend to we do get all the periodontal pathogens, but we also get sort of random pathogens and more opportunistic pathogens, like we get viruses, we get fungi, so you can get Candida albicans, for instance, in a periimplantitis lesion, and Staphylococcus aureus, and so things that you wouldn't normally really put together with a periodontitis lesion, and that might be one of the reasons. And obviously, with a reduced vascular sort of supply, you're not going to get the same immune response as you would maybe with a tooth. You generally see a horizontal pattern of bone loss with a periodontal lesion. Again, I accept that you will often see some angular defects, but with a periimplantitis lesion, it is significantly different in that you generally tend to find that it will initiate on the buccal aspect, but it will become circumferential fairly quickly. So if it's originating on the buccal aspect, to see it on a radiograph, mesial distal, the lesion is probably quite well established, but we'll talk about that when we look at the radiographs. So it's definitely a significantly different pattern of bone loss. Again, I think this is pretty much a standard. Don't really need to talk too much about this. You know, much easier to decontaminate, although people in some cases on, you know, upper and lower eights might beg to differ. But, you know, you've got threads and you've got smooth bits, you've got rough bits, you've got all sorts of sort of angles going on with an implant. So it's definitely harder to decontaminate. And keratinized mucosa. So generally, you will get more keratinized mucosa around a periodontal lesion. And this keratinized mucosa can play quite an important part. Lack of keratinized mucosa can make the oral hygiene measures that a patient puts in place quite difficult, especially when, you know, they are trying to do a really good job. It can be quite traumatic if they don't have enough keratinized mucosa. And Will Workshop, when they looked into it, couldn't actually say that it was a risk factor for developing into peri-implantitis. And they said that they needed more evidence. But in terms of the keratinized mucosa, they were thinking that it is definitely going to inhibit a patient's ability to perform home biofilm management, and around 2 millimeters is sort of the cutoff. So if you have less than 2 millimeters of keratinized mucosa around the implant, then the patient is likely to have a little bit more of a challenge when they are trying to perform their home biofilm management. So all of those differences and similarities, they would then necessitate a different approach in terms of our clinical aspect. So obviously, as we've just discussed, the implant is susceptible to bacterial challenge in a more heightened way than a tooth would be, or the periodontium would be. You're going to have different diagnostic parameters. Probing and instrumentation techniques will be different. You'll have a different radiographic and recall frequency. And you may give slightly modified oral hygiene advice. So if we look at classification, so that we are able to go through our clinical exam and understand the point we are getting to. So peri-implant health. And this was initially Will Workshop, and it's the first time that any classification system has defined health well, it's the first time it had defined implants at all, but it was the first time for health with both the periodontium and the peri-implant tissues. So it really is a step forward. And we are looking for the absence of visual signs of inflammation, absence of profuse bleeding on probing and or suppuration. And it can, like a tooth, exist around normal or reduced bone support. Now, the reason why there are two references at the bottom is there was a slight change when the S3 came about, which I will talk about when we talk on our next slide, which is perimucositis. So perimucositis is bleeding on probing and visual signs of inflammation. And this is where the change came. It is more than one dot or spot or a presence of a continuous line of bleeding or profuse bleeding. So health could actually be if you get one dot of bleeding on one aspect of your 6-point pocket chart, it may actually be a false positive. So just be aware of that. I think if you're not sure, treat it like it's mucositis, because let's just have a belt and braces approach. And as we talked about, it is a precursor for implantitis. And then peri-implantitis. So reversible irreversible, I should say. Crestal bone loss, wouldn't it be lovely if it was reversible? May be evident on radiographs. When I say may be evident, obviously we may have buccal bone loss that's not yet evident, mesial distal. Bleeding on probing and visual signs of inflammation. An increase in pocket depths, recession, and exudate and suppuration. So the top bullet point there, the irreversible crestal bone loss, is the only one that actually has to be there. So the others can be a plus or minus, although I've never seen an active periodontitis lesion that doesn't bleed and actually doesn't have signs of inflammation. But certainly an increased pocket depth, recession, and suppuration exudate they can be there, but they don't have to be there to make a diagnosis. I would also just caveat that with, you can actually get exudate with mucositis. It's more unusual, but it isn't an absolute no. So what we're all here for, let's have a look at the diagnosis. We've formulated a diagnosis through our clinical exam. And when I say we, myself and Jenny, my colleague who run our course, we talk about the puzzle of diagnosis. And the reason why we talk about that, and we have touched on probing very slightly, is that probing an implant is actually really quite a difficult task. And it's difficult in terms of being reproducible and it actually giving the value that maybe it would if we were probing around periodontal tissues. So periodontal tissues, we know with bleeding in a non-smoker that it is a really good indication of disease progression. So we know we get bleeding on probing and there are things going on. With implants, that's not always the case. So we need to look at every other aspect of our assessment to put the pieces of the jigsaw puzzle together. And we're going to fill these pieces of the jigsaw puzzle. So initially, we're going to take an implant history. So we want a brief history of where the implant was placed, how long ago it was placed, is it screw retained, is it cement retained? I mean, you can go even further, and was it placed in a two-step approach or a one-step approach? You know, was the tooth taken out years ago, or was it not? And a good thing to actually ask as well with the patient is, how did they lose their teeth in the first place? Because that will give you a good idea if they were periodontally involved or not. So there is another reason why we ask about implant history, and certainly about the amount of time the implant's been in situ, which we'll talk about when we get to radiographs. The next thing we're going to do, well before we pick our probe up, is do a really thorough visual inspection. So we're going to examine the soft tissues and identify a baseline appearance. Even if that baseline appearance is atypical, and obviously you'd be checking with the implant dentist for anything that you didn't feel looked typical, but we want a description of that just so that we know exactly where the patient sits the first time that you see them. Really good way of backing that up is to take clinical photographs, and we take intraoral photographs now of all of our implants, and we would normally take them at baseline and then probably sort of a year to 18 months after baseline. You want to be looking on that visual exam as well, not just for inflammation, edema, erythema. You want to be looking for biofilm. You want to see if there's any plaque retentive factors there. And this kind of thing is what you'd be obviously ringing alarm bells. And the top left-hand picture really is quite a aggressive and progressed peri-implantitis lesion, and you can see there's quite a lot of loss of contour and that really shiny look that it's got, and that really is indicative of bone loss on the buccal aspect. And then we've got the calculus on the lower right and the upper right. It's not the upper right, is it really? But you know what I mean on screen. That those implants, that this is actually the same person. And this lady is really severely periodontally involved. She's absolutely lovely. Unfortunately, she hasn't really got a handle on her oral hygiene, and certainly not around her implants. Now, last time I saw this patient, she actually had an implant in the lower left one region. And when she came back, that had failed. It had been explanted. And her brother-in-law, who is a dentist in another country, had put an implant in the next door region. It's so difficult to sort of navigate these things, but yeah, these are the kind of things that we're faced, really. And you can see there's quite a lot of calculus there on the lingual aspect. You're also going to be looking at these types of things. Hopefully nobody's having the lunch or evening meal at this point, because somebody on that right-hand side has definitely been saving theirs for later. And this gentleman on the left-hand side, and the reason I put this photograph on specifically is that this presentation of the gingiva and this sort of demarcation that you can see where you've got like a line and then sort of a more bulbous presentation is actually really common with implants. And you can see there the patient's got quite a lot of calculus on the medial aspect. Now, this patient had some missing teeth, and he had implants placed when he was around 18. Now, we probably wouldn't do that because, as you can see here, he's actually continued to grow, or his jaw certainly has, and that has put these implants in a position which really isn't ideal for the rest of the mouth, and probably the reason why he is struggling a little bit with that home biofilm management. The next thing we do, again, we've still not picked our probe up, we're going to palpate. So palpation can be done in really, I suppose, any way you want it to, but most ideal is a finger and thumb. So you've got your finger in the buccal sulcus as high as you can, but certainly as high as where you feel the apex of the implant is. And then on the palatal lingual aspect also, you're going to press your finger and thumb together and then push them down the mucosa towards the margin. And you need to be able to see the margin to see if there is any slight suppuration, bleeding, exudate. So if you find that there isn't a lot of room, you may want to do this as a singular procedure. So you will put your finger in the buccal sulcus and push downwards, and then you would do the same on the palatal or lingual aspect, just to see if there's any of positives for suppuration, bleeding, etc. And this is me palpating one of my patients. So this patient is she's probably about 55 now, and I've been seeing her for, maybe about 15 years, possibly a little bit longer. She lost her teeth when she was around 40, so I started seeing her when she'd lost all of her teeth. And you can see here that these are suppurating and there is implantitis in all of these implants. She's a 20-a-day smoker, and it's definitely a challenge. She has implants in the lower arch as well. So radiographs. The image of choice would be a PA or a vertical bite wing. Obviously, if you have a full arch, you might struggle to get a holder in around the prostheses, and it might need to be an OPG. but in an ideal world, we'd want a PA really. You should be able to see crestal bone height. If you can't, then you really can't assess long term. A radiograph should be taken at baseline. So at the restorative appointment with the restoration in situ is the most ideal scenario. It's easier to assess bone with the restoration in place rather than having it one without the restorative work on and then the next one with. It just makes it a little bit easier if they're both in the same situation. You would then take one 1 year later, which I'll explain in the next slide. And afterwards, you would be basing your justification for a radiograph on clinical need. Most of the associations, so ADI, BSP, and CG Dent, which was formerly FGDP, would recommend that there is no situation where you would be taking routine radiographs for anything, not even implants. And there are lots of practices, dentists, who are still taking routine radiographs for implants. That said, it is fairly easy to justify a radiograph on an implant, so don't worry too much. And this is the reason why, one, we need to know how long the implant's been in situ, and two, why we need those radiographs, one at the restoration and one 1 year later. Because we have some physiological bone remodeling in some cases, not all cases, but in some cases, a little bit like you would get when you have a tooth taken out, say. So we would accept up to 2 millimeters in the first year of that implant being in function. And thereafter, there is a bone loss parameter that we could accept of around 0.2. So that really means that if you've got a patient who comes in, they're new to you, they've had their implant 10 years, 15 years, maybe even longer, and there are no other signs of disease, but they do have, say, what you would class as 50% bone loss, that might actually just be that physiological bone remodeling that's happened. So don't assume that all bone loss is implantitis. And this really is just to sort of reiterate the crestal bone. So this is a radiograph from one of my colleagues, Jenny, and she got this through for one of her patients, and she was not particularly happy with that presentation and didn't feel that she could really do an assessment justice with it. So she took a PA, and she was absolutely right to take a PA because, well, one, you can see that the 6 obviously needs a little bit of attention, and 2, we've got some bone loss on this area of the implant. So it really is important that you have the image that you want to be able to assess from. So when we're interpreting radiographs for our clinical exam, we are not including a percentage bone loss in the staging and grading. So this is a totally separate entity. We are not looking at an implant and thinking, well, that's the worst site, where it's just teeth for staging and grading. We are looking for presence of calculus or cement. If you see it, it's a gift. But, if you see it, then great, you've got to get in there and get it off. We're not going to actually use a percentage bone loss as a method of looking at the assessment of bone. We're going to use a thread count, which I will go through in a little bit more detail on the next slides. And remember, as we talked about before, that the bone loss is usually circumferential. So this implant system is a system that has microthreads. There are other systems that have microthreads, and these microthreads were originally introduced with the hope that they would have osseointegration. And obviously they don't. Well, it might not be obvious, but they don't. So if you do see any of those patients with microthreads, then they aren't going to have integration at that portion. So the macro threads, which are the threads that look like they're a little bit bigger and further apart, the top macro thread is where your acceptable bone level is. So if I arrow that there, so that is your acceptable crestal bone. You then would look at counting down the threads. So on the medial aspects, we have got 1 thread of bone loss, and on the distal aspects, we have got 2 threads of bone loss. This is what you would write in your notes and how you would work at assessing going forward. The reason I've put this up here is this obviously is a full arch patient, and really just to say, in terms of radiographs, I really would strongly recommend that you have a radiograph before you start to treat a patient. And this is the reason why. Because this patient is this patient. And there is absolutely no way of knowing this, obviously without the patient telling you, but certainly from the clinical presentation of that full arch fixed prostheses, you would not know that this patient had a quad zygoma, a quad zygomatic and pterygoid implant and a floating implant in the middle there. This patient is actually the patient that you've just seen me palpate, because those implants were failing. She had explant apart from this particular one, which actually does look like it's got good crestal bone at the anterior region there. It will be coming out at some point, and she does have bone loss on the lower to a certain extent as well there. But just a thought before you start to sort of dive in and do PMPR. The reason for that is that we are not probing, we are not using an air polisher, and we are not using or asking the patient to use a water flosser. The reason for that is that with a conventional implant, we are probing to see if we can detect any bone loss, to see if we can detect a increased pocket depth from our baseline. But with our zygomatic implants, the actual crestal bone isn't there. It's just a soft tissue interface normally, and then the osseointegration happens in the zygomatic arch. So you are not going to find anything out about that patient by probing in terms of, osseointegration, bone loss, etc. You also may get oral enteral communication. So what that means is a little bit like a patient who has their, say, 4 or 5 out, and they blow their nose and they blow a hole between the sinus and the oral cavity. You can also cause issues like emphysema, surgical emphysema with an air polisher. So be very careful before you dive in and start treating these patients. And in terms of radiographs, again, this kind of presentation is quite often seen. And if I tell you that these implants have actually only been restored for about 3 weeks, so the implant that's most distal, I would say probably hasn't been buried as far into the bone as it needs to be. And then this radiolucency that we're seeing on the 6 implants, so the radiolucency on the sort of more coronal portion, is indicative of loss or lack of osseointegration. And if we move on to the next test that we would do, we would test all of our patients for mobility. This is actually that patient, and that is what happened when I tested it for mobility. Now, because that implant has only been restored for 3 weeks, the integration issues were more coronally, but they would have quickly, because I don't think there's integration in much of it at all, it would have quickly become radiolucent all the way along the implant. There are two reasons why implants are loose. One is because they are have a loose crown. So, sort of screw retained or cement retained, they can have a loose crown. That's often to do with occlusion. And then they can also be loose because we've lost integration. If they're loose because they've lost integration, you can sometimes see the tissues move when you test for mobility. If it is just the crown or the prostheses, you need to get the patient back to the dentist ASAP. I mean, in either way, you need to get them back ASAP. But with the crown, there is, and prosthesis, there is a real distinct possibility that they could fracture the actual body of the implant, and then that would be an explant. So we're getting them back pretty swiftly to the dentist. And why do we probe? Well, obviously we've talked about probing and why we probe a tooth. But in terms of an implant, we get lots of pushback about probing, and I certainly don't think most implant dentists would want us to be sort of, getting in there and probing like we'd probe a tooth. I think we need to respect the tissues, but we certainly do need to probe. And we need to probe because one of the criteria for implant health is an absence of bleeding on probing. So you can't diagnose if you haven't tested for bleeding on probing. So it's an absolute must. There is a different technique. It isn't as reliable as a tooth, but it certainly does need to be done. Implant probing, you are going to use a different technique. And as we've just talked about, you're going to consider those limitations. And this is why we've talked about all of the other aspects of assessing the implant, not just probing. So you can see on the left-hand side picture that we've got a situation where the probe is very much standing up and next to the prostheses. And the reason for that is if we came in like a tooth, so you can see sort of a more of an angle, if that probe on the tooth side continued at the same trajectory, it would, if there was bone loss, on an implant, it would hit a thread. And what we want to make sure is that we've got the depth of pocket, which is why we are running really sort of parallel to the prostheses and more sort of down the sulcus. So preparing to probe. Do we need to use a plastic probe? No, we don't need to use a plastic probe. You can certainly use a metal probe if you wish. A little bit of a tip though, I would probably be consistent. So write in my notes, even from plastic probe to plastic probe, to be perfectly honest, you will get different flexibility. So I would even put the make of probe that I'd used in my notes, because you will get different readings depending on what type of probe, and you will definitely get different readings if you are using a metal probe and then somebody else is using a plastic probe. So a little bit of consistency in terms of the probe will help you to be more reproducible. You're going to record 6 points around the implant's restoration or surface. You're going to identify a reference point. You're going to identify actually 2 reference points. You're going to identify a reference point in terms of height, and you're going to look at a reference point in terms of where does the implant sit in relation to the restorational prostheses, and I'll go through that a little bit more in a second. And then a maximum of 0.2 newtons of pressure. And that's obviously in a webinar really difficult to express what that is, but what I would say is we are definitely a lot less pressure than a tooth. So when we talked about reference points, you can see these are probably more of the weird and wonderfuls that we tend to get. And these kind of prostheses that you see here are not done as readily these days, but they are still quite a challenge when you get them. So you can probably see, if I use my little blob to sort of go to where we need to go. If you see here, obviously that's the distal. Now, from what you're going to see, if I run that line across there, that's probably where the mucosa is. So that's what you're going to see. You're going to see anything above that line, you're going to see. Anything below it, you're not. So you putting your probe somewhere along here, you have to be sort of Houdini to get actually into this area here. So you would actually start your probing in this area. And if you think if you've not got any real signs of inflammation or anything like that, and you want to find out where the implant is placed, and you say you've not got a radiograph, I mean, hopefully you will have, but if you've not got a radiograph, have a look, see if it's got a screw hole, because the screw hole certainly won't be here if the implant's here. If it's not got a screw hole, then you might want to get a little bit of maybe floss, X-floss, bridge floss, whatever, and just go under and find out where that stops. So that's where your implant collar is, and then probe from that point there. This implant is like the king of implants, really, because this has got an amazing emergence profile, and this would be, you would probe this exactly like you would probe a tooth, whereas this, you certainly would not. So again, you would be sort of trying to find out where it is. If this is a screw retained, you'd be sort of looking for a screw hole, and wherever the screw hole is, the implant will be directly underneath it. So this is another one of Jenny's. Sounds like Jenny gets all the rough deals, really. And again, anything as I track that line here, this is where the mucosa will be. And Jenny's got to try and get her probe from somewhere around here into this area here. So she would probably go from here and down to here. And this is where this radiograph is absolutely ideal. And it's also really good to show the patient as well, because if you sort of explain to them, actually, this is going to be really quite a difficult area to manage, because there's all of this gap underneath where biofilm can accumulate. So when we're looking at actually probing, we're going to probe our implant separately. So what that means is we're not going to do our 6-point pocket chart with our metal probe and then do 876. The 5's an implant, we'll just probe that and then move on. What we would do is we would use probably a plastic probe. We would probe with a metal probe for our other teeth and then probe the implant separately, or implants separately. I mean, you don't need to use a different probe for every implant, but you can certainly use a different probe than probing teeth. I'm going to probe, as we looked at that picture before, along the long axis at a 0 degree angle, or as much of a 0 degree angle as you possibly can. Remember, some of those with those emergence profiles that are quite difficult to navigate, you're never going to get to 0 degree. So really do, just write that in your notes if you're struggling. And then you're going to walk the probe up and down. So you're not going to do the distal, take the probe out, go to the buccal, put the probe back in, take it out. You're going to dip up and down, walking around the sulcus, and then record the deepest pocket on that aspect. And this is me. So this is the mesial. So you can see I'm quite far over, really. I'm very much buccal there, but this is where the implant sits when I've looked at the radiograph. And you can also see here that this pocket depth is really quite a large pocket depth. You can also see I'm laying the probe against the prostheses, and you can see some blanching of the tissues where I'm trying to make sure that I am at 0 degree. I also then sort of changed my angle slightly, and I did feel that I just nicked the soft tissue, and that is a dot of bleeding. And that would be acceptable for health if there were no other signs of disease. And this patient, the reason why she has such deep pockets, and she's always had them, is because she has a really long smooth collar. So the smooth collar probably measures around 5 millimeters. And this is the complete puzzle. So we're taking our implant history, we're finding out when and where it was placed. the patient may want to go back to that dentist if there are any issues. As soon as you see anything and that you're not sure of, they may want to go back to that dentist for anything that is related to the implant. So it's good to know. Within a visual exam, as we talked about, we're going to palpate. And when we palpate, we're going to ask the patient if they feel any tenderness at all. And that sometimes can be an indication that the implant isn't doing as well as we want it to be if you're getting a little bit of tenderness when you're pressing around the tissues. Remember, we're going to check for mobility, and we're doing that just in exactly the same way as we would with a tooth. We want to have a look at our radiographs. We want to assess the radiographic situation, and we're looking at those radiographs to really direct us to where we're going to probe the implant. And then we're going to probe. So what if you get a patient, say direct access, or a patient who is new to the area, any kind of scenario, and you don't have baseline readings? Remember, baseline is your day one. So whenever you see the patient, hopefully that would be, 3 months after restorative work's done, but it could be 10 years afterwards if they've moved around and they've on new dentists. So what you are looking for to diagnose implantitis is bone levels which are 3 millimeters apical to the most coronal portion of the intraosseous part of the implant. And that statement, for some reason, blows my mind, and it took me ages to get my head around. So if I break that down for you, the intraosseous part of the implant is the bit with the threads on, the macro threads, not the micro threads, the macro threads. And the top thread, if you go 3 millimeters below the top most coronal thread, that is what you're looking at. That alone does not diagnose implantitis. You have to have either or both of the following. So presence of bleeding and or suppuration on gentle probing or palpation, and or probing depth of 6 millimeters or more. Okay, so it isn't just that the patient has lost bone. Remember, if there are no signs of disease in terms of bleeding on probing, in terms of inflammation, suppuration, etc., then it's not necessarily an implantitis case. And these are the supportive care guidelines, and these were set out again in the S3 paper. So they recommend that we are going to do our baseline probing depth within 3 months of prosthetic delivery. We are going to use a probe with a 0.5 millimeter diameter tip and a light probing force. We are going to reprobe at every clinical exam. We're going to record 6 sites circumferentially and also whether there is bleeding on probing. So we are not including this in the BPA. And then assess and record the width of keratinized mucosa. I think for most hygienists and therapists, that would be something that a dentist would be doing, or you would certainly maybe need a little bit of guidance on how to assess that. And then in addition to that, in terms of radiographs, we want a radiograph post-completion of physiological bone remodeling. So the most ideal way of doing that is a radiograph at baseline at restoration, and then 1 year later. And then if we're detecting any pocket depth increase with bleeding on probing and or suppuration, we are then justified to take a radiograph. And this is one of the things we get asked all the time. So what do you do if you can't get around it, especially with the fixed full arch prostheses? How do I get in there? What do I do if I can't get in there? How do I clean it? What do I do, etc. Now, the S3 guidelines have given us an option, shall we say. And this option is only really to be taken if modification of the prostheses or restoration is not an acceptable choice. So the first thing that we should be doing is modifying the prosthesis or restoration. And then if that really isn't feasible, then we can revert to this modified sulcular bleeding index. And this index is really like a marginal bleeding score. So you would get as near to the implant collar as you can and just press around the area and give it a score. So 0, 1, 2, or 3. So just make sure that this is not just like a default, oh, we can't get around it, so let's do this. But really what this is for is those patients that maybe have had implants in a number of years and they aren't in the same situation, maybe in terms of finances or in terms of health, and they just wouldn't really be able to go through the process of having modifications made. And the summary, nearly there. So we are going to record the assessment step by step. So those pieces of the jigsaw puzzle that we put together, the history, the palpation, the tenderness of tissues, I actually have them in a template. So they're just prompts for me. So I have them written down in a list, and then I will dictate to my nurse what I want written in there. And I would be writing, if there are no issues, nil or NAD. Really important that you do write that down. If you don't find any issues with the implants, make sure that you are still going through this process, because then from a medical legal point of view, you are showing that you've been really robustly assessing the implant. Implants don't necessarily need more frequent PMPR, but what they do need is more monitoring. Because remember, if we detect disease, if we leave it, or if we don't detect it because we're not really sure how to detect it, it can become implantitis quite quickly. And then we're in a situation where at some point that implant is probably not going to be there. So we need to be monitoring. And this is a really good point for patients when they are being spoken to about supportive care. We're not there to clean more, we're there to monitor more, so to assess more, just to make sure that there's nothing going wrong. So we are erring on the side of caution. There is no pocket depth conducive with health of an implant. So most implant dentists would like their pocket depths to be 5 millimeters or less. And obviously there's certainly reasons for that. But you will find, again, some outlying patients, possibly patients who had implants done a number of years ago, that do have deeper depths, so sort of 7, 8. I've got some patients with 7 and 8 millimeter pocket depths with no other signs of disease and have been stable for years. So we're not really looking at a pocket depth like we would look at it in terms of a tooth and thinking, okay, so we've got 4 millimeters, there's something wrong. We're looking back at that baseline. So when you've done your baseline around the 3-month mark, that is what you're looking back at each time the patient comes. And when disease is detected, act quickly and decisively. We're not a wait and see situation here. We're not sort of go away, modify this, come back in 3 months. We are on weeks recall for this. We need to be acting really, really quickly to get that area back to health as quickly as possible. And where do we go from here? So, as we said initially, when I started the presentation, we've taken a clinical exam, which is a really important part of implants, or supporting the implant patients, but there is a huge amount to think about. So, we've not really touched on any risk factors for implant disease, and those risk factors really should be trying to be modified. There is some really good stuff if you're into reading papers in the S3 paper about primordial prevention. So it might be worth having a look at that. Modes of instrumentation, again, same thing in S3. There are guidelines to, depending on what your diagnosis is, will depend on what instrument you pick up. How you would treat disease, so how many times you would attempt to treat disease, is also in the S3. When to refer definitely isn't in the S3, but certainly there is guidance on if you've got to the point of treating a patient for implantitis, then really they need to be referred. And that sort of brings me on to looking at a team protocol, and that's really quite important. And I would definitely recommend that as a team, you are definitely not lumping your implants protocol in with your periodontal protocol. We've definitely got two very different beasts in terms of that. So I would be looking at a different protocol. Just to sort of give you ideas, so things like when would you prevent a patient from going forward for implant treatment because of periodontal status? How long does the patient need to be stable periodontally before they have an implant? What medical conditions may necessitate a different approach? What kind of indices would you want as a pre-implant assessment? So there's lots of things to think about in terms of the protocol. And that's it. We are at the end. So you have a discount code, which is WKN0425, and that's valid from last Thursday, which was the 3rd of April, up until the 17th of April. And I've got some QR codes on here. One is to sign up for the Ikigai emails so that you get some notification of any webinars that we're doing. The middle one is mine and Jenny Walker's course, which is a 2-day course, maintaining and treating peri-implant tissues. And then there is also the web shop in case you want to go shopping with your discount code. Thank you very much for listening. I really do appreciate it. And I hope if you have anything that you want to ask me that you will reach out, get in touch. I am on Instagram. We are on Instagram as the Implant Educators, and on Facebook, and you can always get in touch with or on the Ikigai Oral Hygiene community. Thank you very much.